In this episode, I talked with Carla Siegfried, Jacquelyn and Allan Kolker Distinguished Professor of Ophthalmology and Vice Chair of Diversity, Equity, and Professionalism at Washington University School of Medicine, about the gold standard glaucoma surgical procedure, the trabeculectomy. We exchanged detailed tips for success for each step of surgery and post-operative care. It is clear from our discussion that we must continue to train others so that the trabeculectomy does not become a lost art. This is a procedure requiring no special devices and remains the gold standard for achieving low pressures despite its higher complication rate compared to other procedures. There are some audio issues with the recording of this episode that I've cleaned up as best I can. I'm Rob Schertzer, a Vancouver, Canada-based glaucoma specialist, podcaster, and HealthIT expert, and we're talking about glaucoma. Carla Siegfried, welcome to the show.
Thank you very much. I'm excited to be here.
So today we're going to talk about the perfect trabeculectomy, or as I scribbled on my Starbucks thing or during the last talk here, perfect is the enemy of good.
Yes, yes.
And in fact, I once had a talk that he gave for many years called The Relentless Pursuit of Perfection, and it was about trabeculectomy.
And we do all try to pursue perfection with it, but we don't often achieve that.
Now, one thing that kind of scares me, I was talking to another colleague at this meeting, also a glaucoma surgeon, and he hasn't done a trabeculectomy in the past year at all. So what is it with kids these days?
It's frightening, actually. I'm very concerned about how our young trainees are learning trabeculectomy, right. How our mid-level people don't have that extended experience, and it can't be a dying art. It must continue, because when you look at our current knowledge of what allows our patients to retain their sight long-term, it's low IOP. Yeah. We don't have adequate neuroprotection. Certainly our MIGS procedures do not provide, at least our current MIGS procedures do not provide low enough pressures to compete with trabeculectomy, right. Shall we say.
There's always the trade-off,
the safety profile, the safety. Yes. And so safe is great, but efficacy has to be our ultimate
more
goal.
Important, yeah.
Yes.
Because saving our patients' vision is the most important goal.
Absolutely.
Yeah.
That's why we're all here. And if we look at some of the studies, even the primary TVT study, right. TRAB wins, just published recently. TRAB wins in terms of IOP control and number of medications. How that translates into ultimate long-term success with preservation of vision, time will tell. But right now, in 2020, it's our best way to preserve vision.
So how do we do the perfect trabeculectomy?
So
without any visual aids here.
Correct.
Just
yes.
Talking to our audience.
So
imagine, if you will.
One must consider the perfect trabeculectomy in three parts: pre-op, intra-op, and post-op. Preoperatively, you have to have the right setting for the eye. You need to have everything as quiet as possible, be it toxicity from our topical medications, any other inflammatory condition, surface disease, dry eye, steroids preoperatively, minimize the number of glaucoma medications, even consider a short run of oral Diamox to get you over the hump, to get things quiet. I always use topical steroids for a week or two pre-op. Again, it depends on the situation, whether you have that luxury of time, whether you have that luxury to hold off on some of the medications. Treating blepharitis, not only for prevention of potential infectious issues post-operatively, but also just the overall inflammatory component. We all know that blepharitis, dry eye are inflammatory conditions, so treat that.
I think somebody quoted a figure like 78% of our glaucoma patients have meibomian gland dysfunction. Is that
I would venture that, because
or?
I would venture to say that's probably not far off, because now that we have electronic records, it feels like on every patient when I'm dictating to my scribe, I say MGD, 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 whereas I don't think I documented it prior to EMR. It was just an extra 3 letters that I didn't record. Now there's a checkbox, and I think if I reviewed, that's probably not far off from reality. I use topical antibiotic ointment, erythromycin at night. I'll use even oral doxycycline in certain cases when it's
so
really
at least
severe.
Pre-op,
yes,
nice and quiet.
Yeah, not for months and months, but just low dose doxy for a week or two. It can really make a difference. These people that you look at them and you see this meibomian ooze. And then then
going back to what was learned from the 5FU study, your big pressure drops leading to choroidal hemorrhage.
So yeah,
pre-treat.
I definitely will pre-treat. Usually I don't use mannitol unless the pressure is over 30 or 40 there on the day of surgery. And it's amazing that even by stopping a drop for a week or so before surgery usually does not cause that high of a pressure. So then on the day of surgery, in terms of management, I use topical lidocaine gel. Preoperatively, I'll put in a drop of phenylephrine preoperatively, and that will help with control of bleeding at the time of surgery. It just helps a little bit. And then for my procedure, again, good visualization, very, very important. Place my 6-0 silk, and then a very tiny nick in the conjunctiva, and inject a bit of lidocaine. And that will help to elevate the tissue. You have this beautiful plane between subtenons and conjunctiva tenons and conjunctiva on one side, and then episclera on the other. So you've then dissected this plane. Even if there is some scarring at the limbus, you now have this beautiful plane.
Yeah, I do that as well.
I use the mini Westcott scissors, which are sort of a in between Van Ness scissors and the standard Westcotts, because I try to keep my peritomy small. The smaller it is, the less you have to close at the end.
And the less trauma you're doing to the eye.
Absolutely, absolutely, I agree. And then I dissect with my Blumenthal conjunctival dissector, which is basically a little tiny flattened ball at the end of a stick. And it will not.
A10 Blumenthal has been on the show.
Oh, really? Okay.
Yes.
I've never had the pleasure to meet him, so that would be exciting to meet him perhaps someday. I'll put that on my bucket list. And it's a beautiful instrument. It's so simple, but you're not sticking a scissors where, especially as I work with trainees, I'm watching them chop around in the tissue, which I cringe. If you can't see what you're cutting, I've seen it.
Blood vessels.
You can imagine it. I've seen it. And you just, you don't run into trouble, and as best as you can. So I don't use any of the special clamps, and I've considered that, but I will reach under and grab tenons with a serrated forceps, and rather than grabbing the edge of conjunctiva, touch that edge as little as possible. Make a broad sweep, and I'll push that dissector to the hub almost. You want that flow to be posterior. If you've dissected that plane, you can have a very large posterior bleb. Next, cautery. You don't have to over-cauterize. You don't need to cauterize right at the limbus.
You don't need to create a big astigmatism.
Correct, yes. As we learned that's a risk factor for astigmatism. And the flap, it's usually, I don't measure anymore, but when I'm with trainees, I'll measure between 2.5 and 3 millimeters, and it's pretty much square. I actually prefer a square or rectangular flap because with a triangular flap, I believe you have less control of flow. And so if you consider the fact that your sclerostomy is in the middle of the anterior edge of your flap, if you have diagonal edges that go to a point, as in a triangle, there's more chance that you're going to have excessive flow and you're putting in more sutures. It's personal preference. I have no data to support, and nor does anyone else, between a triangle and a rectangle.
Right. I do something in between. I do a trapezoid.
So
it's a little bit wider
yes.
at the limbus.
Yes. Okay. So you have a little more security because you don't
and more
want
coverage
that flow.
Of the internal opening.
Exactly. You don't want that anterior flow. And so when I do fashion my flap, again, adjusting for refractive error per se, because high myopes will have thinner sclera for sure, but get a decent thickness, 50%. You don't know where the other side is, but just get a decent flap. So sometimes you'll see a little more choroidal show, as I call it. It looks more gray versus it just looks completely white, but you have a nice flap. And you get in that plane. I use a crescent blade, and you get in that plane and you just slide. Again, as I'm teaching our trainees, it's not this pushing and jabbing and sawing action.
Right.
It's a smooth push through the tissue. You shouldn't have little jets. But if you retract the flap backwards, you can see where you are.
It's amazing what direct visualization can do for you.
Exactly. So the concept when people were doing scleral tunnels for cataract surgery and they were comfortable with that, then you would cut down the sides of the flap because we would make that our, a single site phaco trab. Now that we virtually 100% of the time do a phaco through clear cornea, you're using a separate site for your trab. So you're going to be sure to go as far anterior as possible centrally, but don't go so far anteriorly towards the edges because you don't want that excessive flow. If there are vessels that you notice, if there are those big episcleral aqueous draining veins,
don't do your flap there.
You can have it in the center of your flap. That's
but not
fine.
At the edge.
And usually there is one right at 12 o'clock. Yeah. And I usually move my flap a little bit nasally to save room for a future tube. It makes it a little bit easier. So I do go just a little bit nasally, but it's still within the confines of that bed. If it's at the edge and then you're left to cauterize it, you have this distorted edge and you always have to put extra sutures there.
I forgot too, the incision, straight up at 12 o'clock or are you off to one side?
I'm a little bit off nasally, just a little bit. Okay. So I would say my sclerostomy in the right eye is at, maybe 1 o'clock, between 12:30 and 1 o'clock, just a little bit off.
And why do you opt for that?
Just to save room for the temporal, for another procedure, too, usually. But if it's perfect, you'll never have to do another procedure.
Right, exactly.
I then instill a myotic, usually myocol, myostat, whatever you prefer, because it really makes a difference in terms of iris prolapse. It will help, even though you don't have to do an iridectomy in a high myope, pseudophakic, who's on anticoagulants, you do need to be prepared to do one. And I would say 95% of the time, I do a very small basal peripheral iridectomy.
So do they get pilocarpine pre-op or you just
No, I just inject it, I inject it, which I know is cost and it's Canada, so it's, they may not allow you to use the myocol, but we have not been, I do put not a huge amount of viscoelastic in, but we don't want the chamber to shallow, especially in a phakic patient. And with the 15-degree blade, I enter at the most anterior aspect of this dissection. I even push the flap anteriorly with sort of the edge of the blade and go down straight perpendicularly. A lot of people will bevel it. They will tend to bevel it and then bring their punch in as well at a bevel. In a beveled fashion. I keep it straight perpendicularly, and then your entry is absolutely, it's really a corneectomy. It's not a trabeculectomy. You really often are anterior to Schwalbe's line. If we did histology, we would know that.
So you're basically, would you say you're just at the end of the vascular arcade where you're entering the cornea?
Yes, more or less. That's probably accurate. And then I take maximum of 2 punches. My Duckworth punch is 0.75 millimeters, 750 microns. And there was a study once a long time ago that showed that it needed to be at least 500 microns. Bigger is not better. If there's flow, there's no obstruction, there's flow. A hole is a hole. And then it's a matter of...
and you go quite vertical with the punch too.
Correct. Yes. Because then you're not going to have this beveled edge that could be a flap.
To the sky.
Correct. Yes. And then comes the art of the procedure, and that is
which is the next 3 months.
Right, exactly. Yes. Well, the closure of the flap, having enough sutures. It's okay to have too many, but it's important to have enough.
Yes.
And I am meticulous about irrigating out all of the viscoelastic and assessing flow. And I do it a few times. It's not just once, oh, looks good, we're done, let's close. I will inject BSS, irrigate out the viscoelastic, and then observe the flow. If I see a gush, if you see this stream of fluid, you know you're going to need additional sutures. It will shallow. It may not shallow, it will soften significantly. And so I routinely put in 2 releasable sutures at either corner, and I like releasable sutures that are buried in the cornea because then I don't even have to move them to the laser. It's right there in the office. I grab a forceps, and it's very easy, especially in patients with thicker tenons where it may be more difficult to visualize. Yeah, it's really, really hard. And then I will assess flow, and the way I want to leave it, and again, it depends on what that pre-op pressure was. So if the pre-op pressure was 35, I may aim for a pressure of 18. And if the pre-op pressure was 17 and it needs to be 9, then I will aim for 10 to 12. I virtually never aim for anything less than 10. And that's the art of assessing IOP intraoperatively by touching the cannula onto the surface of the cornea and feeling what it's like. And I really aim to teach my fellows, and I test them. And I'm usually within a point. I'm always correct. No, I'm the standard, and they will, yes, and they will, I'll say, no, that's too high. No, you need to loosen that suture. We need another suture.
Do you ever do intraoperative tonometry?
I don't. Just experience. I can tell what the pressure is. And you really can by feeling how soft it is with the cannula. Some of them, and I think some of my colleagues use fingers. I don't like fingers, just use a cannula. And then I put in additional permanent sutures. It is rare, but occasionally all the excess flow is through the posterior edge of the flap between my 2 releasables, and I will place a 3rd releasable. That is pretty rare, but I have done that. And then I go on, I take one last swipe with the Blumenthal, because sometimes, I skipped the mitomycin, but we all know the mitomycin step. Keep the sponges back from the limbus, never anywhere near the limbus. I do not place them on the flap like we used to do in the old days with 5FU. But keep it very posterior and a
so
broad.
You have a nice low diffuse blend.
Correct. And as a general rule, I use sponges and not injection. And here's why. The studies, there's not much difference in terms of IOP and the appearance of the bleb. There may be a little benefit to injection of mitomycin. However, you can't take away injection of mitomycin. So when you open and you think, this is a 65-year-old gentleman, he's probably got pretty nice tissue.
Yeah.
There's no turning back. And you look and there's no tenons. None. It's usually the 85-year-old ladies, but you can be surprised. And there you've already placed a load of mitomycin.
What do you use for your sponge?
Actually, we use the commercial Mitosol, and it has small Miracell sponge segments in it. So that's what we use. In the old days, we used to cut apart the Miracell instrument wipe and put those on there.
And that old adage that you only remember the complications, or I guess some people only forget their complications. Having lost a sponge once and having to fish it out, I switched to using mini neuropatties. They're 5 by 5 millimeter sponges that have a suture, like a string attached to them. I use 2 of those.
Oh, interesting.
Way back there, and I can just pull the string.
We all count together in the room,
Yeah.
and I say,
How many
okay,
pieces?
1, 2, 3.
Yeah.
We time it, and then we all make sure there's.
Yeah.
I've had it where it has gone under the superior rectus, and it's even though I usually try to place it on one side or the other, occasionally somehow it gets there, and I've had that panic moment before. Where's the third sponge?
In terms of intraoperative bleeding, when cautery isn't doing it, do you have epinephrine handy?
We do. It's rare. It's very rare that I've used
just some
that.
people are vasculopaths.
Yes.
So I find that it's always handy to have.
And that reminds me, I do not discontinue anticoagulants as a general rule.
Neither do I. Life is more important.
Correct.
Yes.
The CVA is worse than an NLPI, and I discuss that with patients. Sometimes they're on Eliquis, and it's not for a great reason. And I talk to their cardiologist, and they're very comfortable discontinuing it for a couple of days pre-op, but I immediately restart it right after surgery.
So we've dealt with pre-op and intra-op.
Yes. Well, I did the closure.
Oh,
the closure.
Sure.
So my closure is a running horizontal mattress, kind of a modified Condon method, and I use a 9.0 Vicryl on a VAS 100-4 needle. So it's an amazing needle, and it's a special order suture, but I love it. So.
And when you get to 9.0, you hit monofilament.
Yes.
Instead of being two filament.
Yeah, and I work as hard as I can to have the conjunctiva flip over the knot so you don't have exposure, but it's not always perfect. So post.
Yeah, because if you try to run the one that isn't a monofilament, it starts to fray and you're stuck.
Yes. Yeah.
I'm do the wing suture at each end and a horizontal mattress in the middle,
center.
But I make sure it's not leaking.
Correct, and put in more if you need it. Yeah. And it just depends on the tissue. I mean, sometimes you can draw it tight like that, but other times it just. So post-op. Post-op is critical. So steroids is number one, and I use steroids for a couple of months, really up to 3 months post-op. I start out with pretty high dose. I use difluprednate or prednisolone, depends on cost issues, and occasionally preservative-free dexamethasone, which is not always easy to get, but we have a pharmacy that will make it up for us.
Not as potent though either, right?
Oh, you could get away. The Dex is actually pretty potent. I mean,
that would be 0.1%.
Yes, and I will use that QID sometimes at the beginning, every 2 to 3 hours, which is how I use Pred for the first week.
I use Pred every 2 hours for the first 3 weeks.
I routinely use difluprednate because I use it QID. And usually if they can get 1 bottle of it, it'll last me the first month to 6 weeks, and then they can switch to prednisolone after that. It's just.
Was there a shortage here in the States recently?
For Pred or the difluprednate?
Difluprednate.
Not that I know of.
Okay.
I haven't heard that one yet. Shh. There's been a shortage of everything else. I used to use atropine when I was a fellow.
Yeah.
And I stopped because I could not find a good reason for it. I don't have shallowing. In those rare cases that there is shallowing, then I would initiate it.
Yeah, that was part of the Maltino cocktail way back in the days, and sort of was carried on, not from any study, but supposedly pulling the ciliary processes back.
Right, for deepening, but.
Right, and also some potential anti-inflammatory effect too.
Right. And if that's the situation, I can always add it right away. But my patients usually don't. They go to work right away, so they want to have their accommodation as much as possible, and their overall quality of vision. I use antibiotics for a week, just because, and I also restart antibiotics and use them for 3 days after pulling a suture, because there is a small epithelial defect.
Any betadine when you pull the suture as well?
No, I don't. I just pull it. The sterile forceps, but I don't use it.
Any non-steroidal anti-inflammatory?
I don't routinely. I do not routinely, but I don't on my cataracts either. So, if someone is high risk for CME or they have baseline CME, sure, but that's pretty rare. So then,
timing of
so
releasing.
yes, that's the art. That's the second step of the art. And I never remove a suture less than a week out. I mean, if it's 6 days or 8 days.
Except when you do.
Except
right?
when I do, yes. But as a general rule,
Absolutely.
it depends on the timing of that first visit.
Yeah, because there's once you do that and the chamber's flat, and
Then you are,
hemorrhage,
you're royally in trouble. So I will remove a suture early, that is at 1 week, if one of two things is present. One is there's a lot of injection. I cannot massage behind the flap and easily increase flow, because just a high pressure is not a reason to remove a suture.
If you do a little massage and it goes right down.
And it goes right down, and you can see where the flow is, you're fine. If you massage and nothing happens, then I gonio. If there's a big blob of heme, that's one thing. If there's some other untoward substance blocking the sclerostomy, namely vitreous,
that sponge,
capsule, the sponge,
no.
Iris, then removing the suture may not be appropriate. You need to manage what's occluding it first. I will remove one suture if there is blood, and rare cases of injection of TPA or something like that. Yeah. That's really rare. So I would remove a suture if there's a fair amount of injection, elevated pressure. But usually I wait. The popular times of suture removal are at 2 weeks and 3 weeks. And
I try to get them to 3 weeks.
Yes, but 2 weeks, if they have a fair amount of tenons, I'm okay with that.
And oftentimes, I'd say 90% of the time, not removing any suture.
Oh, yeah. Depends on what your flow state is.
So if I'm may just be anecdotal. If it's a combined procedure,
you're a little more aggressive.
It's more likely to.
Yes, yeah. I think off the top of my head, I would say 75% of the time I remove at least one suture, and 50% of the time I'll remove both, and then cut others as necessary with laser.
No, I'm a laser suture licensed person. I don't have the.
You don't have releasables, so you cut them. Same thing. It's the same thing. I just find it easier. It does take a couple more seconds to place a releasable, but not that long. It's not that much of a difference. I would venture to say less time than walking them to the laser.
That's true. But when I do it, I use the 810 Blumenthal laser suture license.
Yes. Okay. There you go.
Another plug.
No financial interest, I'm sure. Yeah.
Not for him either.
Yes. The key is to keep the flow going, keep the steroids on board, and always reassure patients that the blur. So in terms of blurred vision, just one comment, that the more severe the glaucoma is, and I tell them this beforehand, you may have more compromise of your vision initially, and it may take a little bit longer to resolve.
I try to warn them. It could be 3 months before they stabilize with the vision.
Yes.
Try not to worry about it.
But
I have to say it again several times post-operative.
I know, yes. And they, in their 20/30 on day one, they're like, it's blurry. Yes. Is this supposed to be this way? You have two nerve fibers that are functioning. Yes, it's just great. Thank God we didn't snuff out. Yeah. So that's my trab in a nutshell. I think.
The perfect trab.
Yeah.
All right. And I hope all the young ones out there are listening.
Yes. It's really critical that everybody. I like the analogy of, it's great to do laparoscopic cholecystectomy, but you have to know how to do an open wound as well. You have to know how to do a full laparotomy.
Thanks for talking about glaucoma.
Thank you very much.
That's our show for today. Talking About Glaucoma is a podcast of indeterminate frequency and duration, recently averaging 4 episodes per year. I'm still hoping to get this out monthly in the future. It's available for free on Apple Podcasts, Spotify, Google Podcasts, Pocket Casts, Podcast Addict, and many other podcast services. Please rate the podcast on your podcast player of choice, subscribe to it, and tell your friends about it so that it can reach more listeners and encourage me to continue to produce new episodes. Follow me at West Coast Glaucoma on Instagram, and Talking About Glaucoma on Facebook. Drop me a line at podcast@iguy.org. That's podcast@iguy.org with your show ideas if you would like to be on a future episode or questions you would like to have answered on future episodes. Keep informed to prevent needless loss of vision from glaucoma. See you next time on Talking About Glaucoma.